So you'll keep using those. Anyway, all right, so moving on. So we talked about the different types of cell receptors. Now let's go on and talk about the secondary messengers, and then we'll also lead into dose responses, right? So how do we actually respond to those drugs that we're being administered? So secondary messenger systems, as we'll find, we're going to cover those today. After those initial cell receptors are being activated, what is the downstream effect after that to cause my blood pressure to drop or my heart rate to increase or whatever it happens to be? The more common ones we're going to talk about today are going to be things like cyclic AMP or cyclic adenosine monophosphate, cyclic GMP or cyclic guanosine monophosphate. And then we'll also see calcium. Calcium is actually a very, very important cell signaler. It's also really important for things like clotting. It's important for things like muscular contraction. You're going to see calcium become a very important molecule. But also phosphononiositide is one that is working with calcium in these cases here. Again, you can see these either being activated by enzymes, right? So enzymes may be affected, like, say for instance, like a G protein causing that GTP to form to cause those G proteins to activate. Could be things like opening of ion channels. Some of these are going to be voltage gated or voltage linked, so that way when the voltage of the cell changes enough, you can cause one of these molecules to be activated, essentially, right? So there's different signals that can happen here. But once these are activated, then can go on and have whatever downstream effect. And we'll look at some specific drug examples and how that actually occurs and some of the things you might see in your clinical practice one day. So cyclic AMP is generated by using ATP, which again, adenosine triphosphate, right? It's the main energy currency within the cell. We're going to be undergo activity by adenylyl cyclase. So see, AC stands for adenylyl cyclase, and it will convert it over into cyclic AMP. So ATP turns into cyclic AMP, and then this can actually target protein kinases. Whenever you hear protein kinase, it just means it phosphorylates something or adds a phosphate group onto it, right? So we'll look at some examples. Some things that can be affected by cyclic AMP include things like ACTH or adrenocorticotropic hormone. Anyone know what ACTH does? Yeah, it stimulates the adrenal glands, release things like cortisol, right? Glucagon, anyone know what glucagon does? Stimulates blood sugar production from glycogen within the liver. It's one of the primary things you're going to see there. Good. So when you're hypoglycemic, glucagon gets activated. Thyroid stimulating hormone. Go ahead and imagine what that does. Stimulates the thyroid, right? And then vasopressin. Anyone familiar with vasopressin? Does it lower the blood pressure or does it increase it? Actually increases it by, because it's an antidiuretic hormone, right? So anti-P hormone, essentially. So it prevents you from using the restroom. ADH, antidiuretic hormone, vasopressin, those are all different names for the same thing. So we'll look at some examples of how cyclic AMP can be useful to cause whatever effects they're going to have here. So, and again, looking at this would, in this case, be a adenylyl cyclase molecule that's linked to a G protein. So imagine you have a hormone, which again is that first messenger activating the G protein. Again, remember GTP gets formed here, and that can then go along and then activate adenylyl cyclase. Adenylyl cyclase will then convert ATP over to cyclic AMP, and then you're going to have these protein kinases become activated. And depending on what those are responsible for, depending on their amino acid sequence, how they've been spliced, essentially, you're going to find they can do things like they can stimulate enzymes, they can activate gene transcription, they can do all sorts of things downstream, right? So we'll look at a few examples of this. Just another picture kind of showing the same thing, where again adenylyl cyclase becoming activated, these protein kinases become activated at that point, right, by that cyclic AMP, and they can go along and then say, cause a new protein to be produced that maybe was not being produced before. Right? Okay. So as I mentioned, it can mediate a lot of hormonal responses, so things like activating gluconeogenesis within the liver by glucagon. We'll see that vasopressin is going to be good as an anti-urination sort of hormone, so we're going to see that can actually retain water within the kidneys. We can look at things like calcium homeostasis via the parathyroid hormone, right? So what stimulates parathyroid hormone to be released? Low calcium or high calcium? Remember? Yeah, low calcium. So again, if you have someone who has low calcium levels, it will stimulate parathyroid hormone to be released to try to get more calcium being taken up from the bone or increase, calcium intake from the GI tract and the kidneys. Again, that is through cyclic AMP, essentially, right? And then one of the big ones we'll run into, because again, my background's emergency medicine, tox stuff. I like, cardioactive meds. I like things like vasopressors, things like adrenaline. Right, another name for epinephrine, norepinephrine, dopamine. Those all work through cyclic AMP as well, as we saw in one of those previous slides. So let's look at some examples. Here is a hepatocyte, right? And so again, the liver is very important for gluconeogenesis. Taking glycogen, undergoing glycogenolysis, and then producing glucose. Don't get bogged down in all the details here, but I just want you to see this as an example where something like epinephrine, right? When does epinephrine get released? Yeah, from the adrenal glands, right? And so you're going to find it's going to be a stress hormone, right? It's going to be something where your fight or flight responses are being activated, this gets released, right? So epinephrine is going to come and bind these G proteins. You're going to find that will activate adenylyl cyclase, and then through these downstream effects, which I'm not going to, kind of labor you guys with, you're going to find that you can eventually convert glycogen over into glucose, right? That stimulation of adenyl cyclase caused the glycogen to be converted to glucose, and then that can be released out into the bloodstream, and then now your skeletal muscle has more fuel for running away from that bear that popped out at you, right? Whatever it happens to be, or that test you might be about to take or something. Usually your glucose levels will increase in those cases. For instance, if you're dealing with the kidneys, right? So looking at cyclic AMP and its effect with vasopressin. When you're looking at vasopressin, you can actually find that you're going to have things like these aquaporin channels will actually become and put into the collecting duct here. I'm sorry, aquaporin channels right here. So basically by having adenyl cyclase being activated by the hormone, antidiuretic hormone, right, or vasopressin, you'll cause more aquaporin channels to be put here. And normally these cells would be kind of impermeable to water. But when you have aquaporin channels, which you might imagine transports water, those will open up and allow water to flow in. And then now I'm holding on to more water. Right? Why is that important? It can affect blood pressure. It can affect osmolality of the blood, right? Because again, antidiuretic hormone, one of the big things that that's responding to is changes in osmolality and changes in blood volume and blood pressure, right? So again, we'll cover that in more detail later on, but that's an important hormone for that. So that's one example how adenyl cyclase can be used to form cyclic AMP to cause more water retention to occur in response to antidiuretic hormone, right? Here's an example of the heart. So imagine you have a sympathetic nerve terminal here that is going to be dumping out onto one of the myocytes, right? So here in this case, you have something like norepinephrine being released in response to a fight or flight sort of stimulation. They'll have a beta adrenergic receptor that will be activated. That then activates adenyl cyclase and will allow more calcium to flow into the cell. And we mentioned when you have more calcium flowing in, what does that do to the contraction of the heart? Increases it, right? So you have increased contractility. So now I can increase my stroke volume. I can increase how much cardiac output I have. And I can increase the blood being delivered to places like skeletal muscle, right? So again, these are all big changes that occur through adenyl cyclase, right? These are downstream effects of the initial drug itself, the ligand of norepinephrine, right? And I can affect that as well as a clinician. I can give someone norepinephrine as a drug, and I can try to increase that contractility of the heart. So if I have someone who has bradycardia, poor cardiac output, I give them norepi and get the same effects occurring here, right? And again, I'm not going to ask you specifically, okay, what does norepinephrine activate for this purpose here? Later on, you should know that norepinephrine activates things like beta-1 receptors in the heart, but we'll get to those specific examples later on in Pharm 1 and Pharm 2, okay? If I give you any like specific drugs on a test, it's going to be, I will explain to you exactly what's happening with it, so that way you don't need to know inherently what these drugs do at this point in the class, okay? So similar to adenyl cyclase forming cyclic AMP, you also have cyclic GMP, which gets formed from guanosine triphosphate, as we'll see. And so basically this is really good for helping to regulate things like ion channel conductance within the intestinal mucosa. This is very important for especially the vascular smooth muscle, right? So this is going to help us to relax the vascular smooth muscle. And what do you think that might cause? Yeah, so hypotension can be a potential cause here. You can see vasodilation occur when you relax that smooth muscle. And so again, this is going to be very important. I'll talk about one specific example here. And here's an example of, let's say, a smooth muscle cell where I can have the agonist coming along, activating guanylyl cyclase. You have GTP converting over to cyclic GMP. So the same process as you would see with cyclic AMP being formed here. And in this case, you would actually have some of these channels actually opening up. You'd have calcium flow out of the cell, and then that would cause the smooth muscle to relax, essentially, right? So I can see vasodilation that can occur there. Now again, guanylyl cyclase is not going to be cyclic GMP does not stick around forever. So for instance, you have an enzyme here, something called phosphodiesterase, will actually come and cleave it and activate it, and that will allow for that regulation there, right? Because again, if I had too much cyclic GMP around, I would get too much vasodilation. I have hypotension. I'd have the person pass out potentially, right? Which is an important drug interaction. So for instance, anyone familiar with the drug sildenafil? Anyone ever heard of Viagra? Yeah, Viagra, right? So Viagra is an important drug that actually interacts with the system. So you imagine someone, what is Viagra used for? Erectile dysfunction, right? And again, usually erectile dysfunction is caused by what? Impaired blood flow, right? Impaired blood flow to the penis, they can't generate an erection, essentially. So what actually happens in this case, you give something like sildenafil that will actually inhibit this enzyme. Your cyclic GMP levels go up. You have high levels of cyclic GMP, and that allows for that smooth muscle to relax, allows for better blood flow. Now suddenly the person can have an erection they couldn't have before, right? Cyclobenzaprine acts through a different mechanism. It actually works through the GABA channels. Yeah. So one of the things you'll also, oh yes, ma'am. Yeah, so not for the heart specifically, but that's actually a point I was going to make. So, for instance, you think like Viagra, who do you think is the prototypical user of Viagra? Middle-aged dudes, right? What if I told you that I'm giving Viagra to little girls? You know, what does that make? So why the heck what do little girls need with Viagra? Well, I'll tell you what. So this smooth muscle is also going to be present in other places as well, not just, you know, going down to the penis, but you can find it in places like the lungs, right? So if someone has pulmonary hypertension, some of those blood vessels are too constricted and they're not able to oxygenate appropriately. I can give them this drug to cause smooth muscle relaxation there and allow for better blood flow coming from the heart. And so you can find pulmonary hypertension is very closely linked to heart issues as well. So that's one of those things where we'll actually give that. We use it quite a bit in our cardiac unit over at Nemours for helping with that pulmonary hypertension that happens there, right? So again, that's why you run into issues where if I had something that were to increase the activity of this system here, so say for, and we'll talk about an example in a minute, if I were to have someone already taking Viagra along with that, you can run into drug interactions. You can see how by attacking two different sides of the system, you can either lead to enhanced effect, which may be good, or more likely it's leading to toxicity, right? So I'll talk about that in just a second here. So again, looking at the endothelial cells, you know, things like nitric oxide, this is one of the main stimulators of this process here. Nitric oxide is directly going to stimulate production of guanylyl cyclase, or activity of guanylyl cyclase, to convert that cyclic GMP or increase that production there and cause vasodilation. So this is the important process here. Nitric oxide, it's not nitrous oxide, that's different. Anyone know what nitrous oxide is used for? Laughing gas, yeah, essentially. So nitric oxide is what actually stimulates this process here. So the prototypical drug you think of as affecting cyclic GMP is going to be nitroglycerin, right? So basically, imagine when does someone take nitroglycerin? Chest pain, right? What is chest pain? Angina. So what is it indicative of? Yeah, so maybe it's coronary vasospasm. Maybe they have a plaque or something, or a blockage that's occurring there. But essentially, what is it telling you when you have chest pain? Less supply of oxygen to the heart, right? So myocardial ischemia is occurring here, right? So again, that's my body telling me, hey, there's pain here. I'm not getting enough oxygen going to the heart. I need to rectify that, right? So one of the ways that we do that is try to deal with that spasm of the vessels there and try to relax them, right? By relaxing the coronary vessels, you allow for more blood flow, you allow for more oxygen delivery in those cases, right? So that's why as soon as you have someone who has previous MI or someone who has angina, they will take nitroglycerin at the onset of chest pain because they know that the longer you starve the oxygen or the heart of oxygen, guess what? More likely you are to have permanent damage done. So anyway, what happens is they'll take nitroglycerin. They usually take like either sublingual tablet or they'll take like a sublingual spray, and they will activate nitric oxide. Okay, this will then activate guanylyl cyclase. That'll stimulate GMP production, and then that will activate some protein kinases in that vascular smooth muscle that will cause the coronary arteries to dilate and will offer better blood flow. Okay, and hopefully the angina is resolved. Otherwise, they need to call 911 and they have that checked out, right? So imagine if I were to have someone who had nitroglycerin being given, right, to activate this process, cause vasodilation, but then I also had them being on Viagra at the same time. That prevents the breakdown of cyclic GMP. What do you think could happen? Severe vasodilation, hypotension, and potential syncope. So, and again, when one of the primary things your body does whenever it's delivering blood to the body is two organs it wants to primarily focus on. What are those two organs? The heart and the brain, right? So again, if I cause severe hypotension, I can then starve those organs of blood essentially. So I can either have the person pass out, or I can potentially worsen the myocardial ischemia because less blood is actually getting to the heart, right? So that's why if you were, say, for instance, working with paramedics or EMTs or something, one of the first questions they ask before they give nitroglycerin is, hey, do you take any Viagra, right? Or at least of people who you might think to be on Viagra, so middle-aged dudes, right? And again, they have chest pain as well. So one of the things I tell them not to mix and match those drugs because otherwise they cause severe hypotension, can worsen the myocardial ischemia, and then you worsen the heart attack essentially. Okay. So just one example. And again, you don't have to memorize that specific mechanism for the test, but just know that these are the kind of things we're going to talk about. When we talk about drug interactions, you're going to be able to know, okay, I see how these interactions are working together because they're attacking maybe the same system from two different sides of the equation there, right? One's enhancing production, one's inhibiting degradation, right? Anyway. All right, up next we have our calcium ions in this inositol triphosphate system, or IP3 essentially. Calcium is much more widely used throughout the body as a signaling molecule. That's why it's so regulated pretty tightly. So again, on the extracellular side, we don't have a ton of calcium floating around, especially compared to something like sodium. And then within the cell, usually it's being sequestered away in places like the sarcoplasmic reticulum, right? So usually calcium is very well regulated because it is going to be causing things like muscle cell contraction. You can see secretion of substances can be influenced by calcium, cell division. So it's really important that we can regulate this, and this is one of the second messengers that helps us with that. So basically, we're going to start off with an enzyme called phospholipase C, and this will make more sense when we actually look at the picture itself. This gets activated by a G protein potentially, right? So again, this is our secondary messenger system in this case, and you're going to find that phospholipase C is actually going to break down this particular phospholipid called phosphatidylinositol 4,5-biphosphate. You don't have to be able to say that. I don't expect anyone to say that. However, just know that it gets broken down into two molecules here. It's IP3 and it's DAG, so 1,4,5-triphosphate and this diacylglycerol. Okay, just know those are the two primary components that gets broken down to. And then what you're going to find once this occurs, it will then dissociate from the cell membrane and then can cause things like release of calcium from the endoplasmic reticulum. Okay, you're also going to find that the DAG is going to be associated with the membrane and then will activate things like protein kinases, similar to what we saw with like things like cyclic AMP, right? So this makes more sense on the picture. So imagine your G protein being activated here. You're going to have this phospholipase C become activated, and it's going to cause this cleavage of the DAG and then the IP3. Okay, so IP3 can come down, interact with the endoplasmic reticulum, and that will then allow calcium to be released, and that can cause whatever effects it's going to have, whether it's to be exocytosis of a hormone or contraction of the muscle, whatever happens to be. Those are the cases there, right? And then this DAG can also help with these activation protein kinases additionally. Okay, so just a different way to get some of these downstream effects to occur. Okay, and just note that there can be multiple signal pathways that basically get the same thing done essentially. So imagine here we have a vascular smooth muscle. You're going to find that there are many different ways to have that muscle interacted with. So for instance, I can have something like, say for instance, angiotensin 2. Ang2 is going to become very, very important when we're talking about regulation of blood pressure, right? A lot of patients are going to have upregulated angiotensin 2 that we want to deal with. This is going to cause things like constriction of the vascular smooth muscle, to cause things like hypertension, right? Angiotensin 2 is a big cause of hypertension for a lot of patients. You can have things like epinephrine coming in, activating with these G proteins to cause cyclic AMP to be modified, so that way you have relaxation, right? So again, depending on the signal, depending on what's coming in, you may find that some of them are going to activate the cell to either contract or relax. So it just depends on what the signals are going to be here, okay? That kind of makes sense? Anyway, so just use that as an example. Okay, so let's get into actually dose-response relationships. And what does that mean? I give you a dose? Yeah, what effects I'm expecting to see out of that, right? So again, and a lot of this stuff is going to be things that are done prior to you, actually the drug ever getting out on the market in the first place, right? So all this stuff is done in preclinical trials and things like that. We're talking about it here because I want you to know that when you're looking at things like drug references and you look to see like, when you're looking at your dosing for the your homework or assignment, right? How did they figure that out in the first place? Well, this is what they were doing essentially, trying to figure out if I give you this much drug, how much response am I going to get? And so that way you at least have an appreciation for, okay, well I know why this drug I give 20 milligrams, but this other drug that does the same thing I only give 10 milligrams. Like how do we get those responses? How do we determine that? This is what goes into that essentially. So in looking at pharmacodynamic studies, usually we're looking at different doses of a drug, either within an individual patient, maybe an individual isolated organ or tissue, or in a lot of cases what you're going to find is done on a group of subjects, right? And so we're looking at different types of responses you can get from that. And usually we're looking at that response between what drug concentration we have, what we think it's the concentration at the actual receptor, and what magnitude of response we're going to expect to get, right? So for instance, if I'm giving you an antihypertensive, and say I give you a 10 milligram dose of the drug and I see a 10 millimeter mercury drop in your blood pressure, if I give you 20 milligrams, you should expect to see a bigger drop in blood pressure, right? Or maybe 20, maybe it's 25, who knows, right? That's what we're trying to figure out when we do these kind of responses here. And so this is important because, we are trying to determine like what's the right dose for these patients. What is too high of a dose? What is too low of a dose? To make sure we're getting the right amount. Because again, we want to make sure that we're giving a dose that is most likely to cause a therapeutic effect and very unlikely to cause toxic effect. Some drugs are more or less successful at doing that, as we'll see. Okay, so usually at a baseline, you need to kind of show three different things when doing these kind of dose-response relationships. First off, you have to show that if the drug isn't there, you don't get any effect. Kind of makes sense, right? When might you not see this? When would you see when no drug is present that they actually do get an effect out of that? The placebo effect, right? So again, placebo effect is a real thing. You can actually see demonstrable effects in the body just by the person thinking, hey, I'm taking a drug for my blood pressure. It's going to help my blood pressure. Maybe they're more relaxed. They know they're doing something for their health, and all of a sudden their cortisol levels go down. They have to deal with the blood pressure. Placebo is important, right? So again, we have to take that into account. That's why when you're doing trials, have you guys done any research courses yet? You'll do them eventually. You'll learn different types of research studies. That's why we do placebo-controlled trials, because we want to see if we just give people sugar pills, what is the effect we're going to expect to see versus when you actually give them the real drug. If they show no difference, then that tells you the drug's probably not doing a whole lot. Versus if you see a big change, then it's okay, yes, that means the drug is effective. Okay, so that's one thing they're going to check. The other thing is going to be when they add more drug, you should expect to see more effect. If I give more drug, I should see more blood pressure lowering, right? And then if I take the drug away, what should happen? You go back to baseline, right? So if I stop giving them that drug, their blood pressure should come back up to whatever the baseline was beforehand, okay? So that shows that when I give the drug, it's actually doing something. When I take it away, it's not doing anything at all, which makes sense. And so typically what you find is you're going to generate these dose response curves, and usually they have this sort of S shape with them. And so basically what you can look at is the log of the dose on the x-axis, and you can look at the response you're getting on the y-axis here. And so when you're looking at this, you notice here that there's going to be a period of time where you're going to have changes in dose should lead to some incremental change in effect here. And what do you kind of think is happening here at this plateau? Yeah, it's when all the receptors are saturated at that point. So even if I keep driving up the dose, even if I give 10 times whatever that dose is, I don't see any difference beyond that, right? So again, that's going to be important when we're talking about things like therapeutic indexes. We're comparing this curve for efficacy versus the curve that we have for toxicity, or potentially the curve for death, right? So, and again, the response can be anything. It could be enzyme activity, it could be blood pressure, it could be the amount of hormone being secreted, it could be anything. So again, the researchers will set that when they're doing their studies. So some of the definitions we're going to run into, and if you can't hear me, do the helicopter, tell me, and I can pause. Can you hear me okay? Yeah, okay. So I'm looking at the ED50. There's like one time I did this class, and it was in the evening time, and they would just turn the helicopter on and just let it run. I guess they're testing it or something, but it seemed like they're doing it just to interrupt our class. Yeah, so it's like, don't you have lives to save or something? Like, come on, guys. Just kidding. No, they do a very important job, so I don't want to worry about that. Anyway, so some definitions. We're looking at the ED50. This means the median effective dose. This basically is a dose where 50% of the population manifests whatever we're looking for, or the sample manifests a given effect. So for instance, it could be 50. If I'm dealing with a drug that causes sleep, for instance, I have 50% of the patients are asleep. That's my ED50. Or if I have a 50% drop in blood sugar, whatever it happens to be, that's my ED50, right? This is important because this allows us to compare different drugs together, right? Now, would I ever dose a drug at this right here? Probably not, right? Because I don't want to give a drug and only have a 50-50 shot of it working, right? I want to have a pretty close to 100% chance that the drug's going to be effective. So you would never actually dose at this level. You probably dose somewhere closer up to here, close to the plateau effect, depending on the drug. But you're going to find this is good. We can actually compare different drugs together. We can determine how potent a drug is. We determine overall efficacy of the drug as compared to one another. So we'll look at some examples of that in a minute here. So the shape of the curve, as you can see, normally it's going to be plotted as a semi-logarithmic graph that helps us to get better comparisons, especially when you're dealing with drugs that may be dosed in micrograms versus drugs that are dosed in grams. That way you can kind of compare one another a little bit more apples to apples, as you'll see. Again, it helps us also, it becomes easier to estimate the actual ED50, so that way when I'm looking at, say, drug A versus drug B, I can make these comparisons a little bit easier, even though the dose may be changing pretty drastically here, right? So again, 300 micrograms versus 3 milligrams, it can become even more drastic than that depending on the scale that we're using. Okay, so the 4 standard parameters we're going to see in these curves, you're going to have a baseline bottom response curve. So again, ideally, if there's 0 drug around, there should see 0 effect, right? So that should be your baseline there. You're going to have the maximum response, which is usually where receptor saturation is occurring. You're also going to have a slope to the curve. And what do you think the slope tells you? How drastic of a change you see in effect based on changes in dose, right? So one that is more steep will show me that just small changes in dose will cause big changes in the effect I'm going to see there, right? Versus something that has a much more shallow sort of slope, you're going to find that I can change the dose pretty drastically and not really see a ton of change in effect, okay? So it basically tells you kind of what range of doses you might expect to see, whether, dose of a drug can, range from, say, 10 milligrams to 15 milligrams, versus somebody's giving between, say, 10 and 100 or something, right? That will go to how steep that curve is there. And then the ED50 is going to be the half maximal effective concentration. Should be located 50% halfway between the top and the bottom of the graphs there, and is going to help us to determine potency. What do we say potency was? How much drug I need to actually cause the effect I'm looking for, essentially, right? So and that's useful for comparing different drugs together. So we can look at a couple of different ways, look at the graph a few different ways. There's what we call a graded response. This is going to be good for looking at various doses of a drug on an individual, right? So if I did one person to see what their change in blood pressure was over the scope of different dosing of a drug, or if I look at a specific tissue or whatever happens to be. And then we're going to have the Quantal responses. This is basically going to be like an all or none phenomenon. So this is going to be when I'm looking at a population, right, or a group of people, I'm looking to see like how many of them manifest the desired response I'm looking for. We'll go into some examples of this in a second, but we'll look at kind of the differences and when you might use one versus the other. So note here that as the concentration of the drug increases, you should expect to see the magnitude of the effect increase to a point. And so again, when you're looking at that response, it's usually continuous, right? You don't see a big jumps that occur there. And again, this is based off this whole equation right here, where as I have more drug, and again, the receptor concentration doesn't usually change over the acute time frame. As I add more drug, what does that do to this equation? drives it to the right, right? So I should expect to see more drug receptor complex. And again, there could be a point where I'm going to reach a saturation where this is all I have essentially, right? So again, it doesn't matter how much more drug I add, there's no more receptors for it to interact with, okay? So again, this is going to be that graded dose response curve where I can look at changes over, you know, a wide range of doses in one individual patient essentially. And so again, it's continuous, it's gradual, versus the Quantal, what we're going to see like an all or none, as so far as asleep or awake, or alive or dead, or whatever happens to be, right? So again, this is more of a yes/no sort of phenomenon. With the graded response, is more of like, okay, at this dose I got 10 millimeter mercury drop of blood pressure. At this dose I got 15. This dose I got 20. Again, it's a continuous sort of relationship. And again, this helps us to determine that receptor occupancy. It helps us to determine at what point do we actually saturate those receptors based on the dose that we're administering there. Okay. And again, when you have maximum response, you should expect all receptors to be activated. When you have half max response, only 50% should be saturated at that point, right? And so again, looking at comparison of these, I can look at things like potency and efficacy, right? So we're going to look at some comparison curves here. Typically, how far to the left or right the curve is shifted is going to determine potency. Typically, the more shifted to the left, when my dose is smaller, the more potent my drug is going to be, okay? The maximum effect here at the top of the graph is going to determine how efficacious a drug can be, okay? So remember that when we're looking at comparing different drugs together. All right, so as we were mentioning, any questions in the first half, I should say? Any questions from the first half? So I had a few people ask me, how do I study for this stuff? You don't necessarily need to dive into the textbook. If you would like further clarification on things, absolutely you can look at that. I recommend focusing on the PowerPoint. If I spend a lot of time talking about something, chances are I probably think that's pretty important. I might ask more questions on that, right? The other thing would be if you want to try taking like sample questions, I would recommend going to Access Medicine. You guys should have access to that through the library. You can make a free account on that website that will allow you to take review questions based on different textbooks individually, right? So for instance, there's one called Goodman and Gilman's The Pharmacologic Basis for Therapeutics or something like that. But it's Goodman and Gilman's, that's like the pharmacy Bible essentially. You can actually go on there and actually look at individual questions based on the different chapters and try to get a feel for those questions will be much harder than what will be on this test or any of these exams, for instance. However, it will give you an idea of, okay, do I know this concept at least somewhat? Do I not know it at all? Those will be the kind of things you can kind of parse from that, okay? I know it's futile to say don't stress about it. Again, know the concepts, right? Again, I'm not trying to trick you guys. Some people overthink the questions very frequently and they end up tricking themselves into the wrong answer, right? The other big thing I always tell people, no matter what, and this goes for any class, don't change your answers. You've probably looked at this stuff enough that you at least have a gut feeling for what the right answer is, and most of the time you're going to be right, okay? If you change answers, more often than not, you're going to end up kind of screwing yourself over, right? And again, because we, you know, my university, I teach at full time, when we have students that come through for test failures and stuff, one of the first questions we ask them is, did you change your answers? 9 times out of 10, yep, I changed my answers. That's what got me. You know, that's what made the 2.4 point difference between failing and passing, okay? So really, 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 I can't stress that enough. Don't change your answers. Anyway. All right, so yes, sir.
Can you clarify the difference between the effectiveness versus the potency?
Absolutely, that was just what I was about to say. So thank you for that segue. It's good. Yeah, so potency is mainly going to be referring to just the amount of drug you need to get a given effect, right? So again, whether I need 3 micrograms of a drug or I need 3 grams of a drug, right? So it can range pretty widely there. Like I mentioned last time, I mentioned morphine dosed in say a few milligrams, right? 2 milligrams of morphine may be equivalent to say 25 micrograms of fentanyl, right? So again, that drug fentanyl is going to be much more potent because I need much less drug to get the same effect out of it, right? That doesn't make fentanyl absolutely better than morphine, but it just makes it more potent, okay? The effectiveness is basically going to be how much of an effect I can expect to see out of that. So for instance, if I was comparing, say, codeine, codeine's a pretty wimpy sort of opioid. I'm never going to be able to get the same amount of pain relief as I would out of something like fentanyl, right? So that would make codeine less effective. And you can actually see that when you're looking at. So going into the potency, again, by comparing the ED50s of various drugs, we can determine how potent the drug is going to be. And typically, the farther over to the left that the curve is, the more potent the drug is going to be. That means I need less drug in order to get the same effect, essentially. Okay. The farther to the right, it's going to mean that it's going to be less potent, as we'll see. So in this case here, which is the most potent drug? A. The least potent. C. Perfect. Okay. So you guys already got that down. That's perfect. Now, if we were to look at these 4 graphs here, again, which one would you say is most potent? A is still going to be the most potent in this case here. Which ones are going to be most effective? A and C. You'd say actually A and C are equally effective. but they're not equipotent, right? I would need more of drug C in order to get the same effect as I would have drug A, and I can determine the max efficacy based on where that plateau occurs, where that E max, essentially, the maximum effective dose is going to be. Now, which drug would you say is least effective? Drug D. Okay, drug D would be least effective. Which one would be least potent? Drug D as well. I'd need the most drug to get out of drug D, but I would never get the same amount of effect as I would out of, say, A or C. Okay, so these are the comparisons that are done, and when you're looking at, say, charts where you're saying, okay, well, I get 10 milligrams of this drug versus 20 milligrams of this drug. This is what they're doing essentially to try to determine what these equally potent doses are going to be, what these equally efficacious doses are going to be for various drugs. Now, does that mean I never ever want to use drug D? Not necessarily. Maybe I don't need that full max effect that I get out of drug A, right? Maybe codeine is all I need in order to deal with a minor pain. Versus if I'm undergoing surgery, I probably want some heavy duty sort of narcotics there. I really want some good pain meds. Or for instance, if I had the choice between two drugs, say to lower blood pressure, drug D is only, say, I can get that on the $4 list at Walmart, $4 for a month's worth of drug, versus drug A, which may be more efficacious overall, but costs $300 for the patient. Which one's going to be better? Because if the patient can't afford the drug, guess what? They're not going to be able to take it. Okay, so again, in that case, a $4 drug might be way better. Even though you may not be able to get full max efficacy as you would at drug A, drug D might be the better choice. Okay, so again, you're not going to be looking at these curves when you're just trying to select out drugs, but this work's already been done for you essentially when you're looking at these drug references. Okay, so again, efficacy is just that ability for the drug to make a given effect here. Now, you'd expect agonists to have positive efficacy, as you'll see here. Now, what about antagonists? No efficacy whatsoever, right? Should just be a flat curve, right? Just like we talked about with naloxone or Narcan, blocking those opioid receptors doesn't ever activate them, even though it can bind pretty tightly. It's going to cause zero effect, right? And then a partial agonist would do what? Yeah, it would have a lower Emax essentially, right? So it would be lower than what you would see with something like a full agonist might be. Because again, when I get that receptor saturation occurring there, it's only partially activating those receptors. I would only expect to see partial max effect there, right? And again, looking at this, you could expect, say, something like drug B maybe is going to be a partial agonist, whereas drug A may be a full agonist, right? In these cases, which one would be more potent? A and B would be the most potent drugs on this list here because, again, the ED50s are roughly going to be at the same dose, right? So, again, even though A is more efficacious, B is equally potent to A in this case here, okay? Now, which one do you think clinically is more important, efficacy or potency? Efficacy trumps all the time, right? Because again, I can change the dose. If I need to give a few grams of a drug, I can do that. If I need to give only a few micrograms, we can account for that. But if a drug is only going to be, minimally efficacious, I don't really care about that drug in the first place. If it's not going to lower my patient's blood pressure, if it's not going to fix their sugars, whatever happens to be, it's not going to be that effective. Yes, sir. Get a question first.
Why would, like something like Narcan, where it said it has zero efficacy?
Yeah.
Then why does the dose itself cause different effects as far as being able to? Half a milligram might not wake them up completely versus a full.
Yeah, so that goes back to the competitive nature of its antagonism, right? So we mentioned that it's all numbers game. So if I have a lot more heroin in the system that totally outnumbers the Narcan, that heroin's going to be more likely to bind to those receptors and the patient doesn't wake up. But as I steadily increase the dose of that drug, eventually it's going to have enough numbers to basically kick off that heroin and then interact with the receptor. So that's why if I give, say, too small of a dose, maybe you don't see any changes whatsoever in the patient. If I give too big of a dose and I kick all that heroin off, guess what happens? They go into a withdrawal, and then all of a sudden they're going to be having diarrhea, and they're screaming at you, and why the heck did you give me that stuff? Spent all my money on that. They get pretty mad at you when you give them too much, right? So again, it all goes back to the dose and that competitive nature of that antagonism. You ever see Narcan reversal? It is. Did anyone actually go look up the YouTube clip I mentioned? Yeah, that's what it looks like. I swear to you, I've seen several of them. That's a bad reversal. Typically, you want them to start yawning and kind of waking up slowly. That's good. Otherwise, it can be pretty nasty. I think you. Mm-hmm.
How so? Because I thought that like the ones most to the left on the points.
Yeah, so the ED50 is not marked on here, but if you imagine where the ED50 would be basically lying at the same dose right here on the, so it really just goes to where the ED50 is on the x-axis at that point, right? So again, the doses between these drugs would probably be similar. However, you'd see that drug B just would never be as efficacious as drug A might be, right? Who's next? I think you were next.
So how do you know how much to get?
That's a great question. Trial and error, right? So a lot of it is you're going to find it's more of the art of medicine rather than the science. In some cases, and it can sometimes depend on where you work, right? So again, a lot of cases, I just want the patient breathing. I don't need them to be awake necessarily, right? And again, your nurses are going to really appreciate that if you can just get them breathing, not awake. Because again, usually these patients are not super pleasant when they're coming in because they probably did not want to be in the ER in the first place, right? So thing is, like, for instance, when we were dealing with something like, so imagine a few years ago, back when pill mills used to be a lot more prevalent here in Florida, prescription drug abuse was much higher than it is now. Now heroin's starting to take over more because we shut down a lot of those. So we used to have a lot of more prescription opioids here in Florida than we did, say, for instance, like in New York. Up in New York, they have a lot of heroin, right? Heroin is very, very sensitive to Narcan. They would only give a few micrograms potentially just to get the patient breathing, right? Down here, you would find that prescription opioids bind a lot tighter to those receptors. You give the same doses you may give up in New York, and it wouldn't do anything. We have to give up to 10 milligrams in some cases of Narcan, which is an absurd amount of drug, but that sometimes is what we needed to get those drugs off the receptor to get the patient breathing again, right? So again, it all goes to like where are you practicing at, what kind of patients are you dealing with, are they opioid naive, are they opioid tolerant? If I have a little kid that gets into drugs like that, but they don't have any tolerance built up to it, I'll give them 10 milligrams and nothing happens, right? They just wake up and that's it. Versus someone who's like chronically on these drugs, that withdrawal is much more of a concern. So those are all like kind of the nuances we'll get into. We had to talk about like specific drug examples in Pharm 1 and Pharm 2. Yeah, for sure. Any other questions? All right, good. And so again, the efficacy is going to be associated more with the vertical axis where that Emax actually is. And again, we'd say A and C would be equally efficacious here. They have the same equal Emax, same top point there, even though drug A would be more potent in this instance here. Okay. Again, here in this example, we said A and C would probably be equally potent as well in this instance here. D would be least, D would be equally efficacious. I apologize. Drug D, though, would be least efficacious out of the bunch. And again, this all goes back to the affinity for the drug to the receptor and also just the intrinsic activity. So we mentioned, like, say, for instance, an antagonist would have what kind of intrinsic activity? 0, right? So it doesn't matter how many of it you bind to, it's never going to cause any intrinsic activity. It goes back to being an agonist, partial agonist, or antagonist there. The affinity just goes to how tightly we're binding to that. So for instance, when that example between, say, heroin in New York versus prescription opioids here, our drugs down here had a higher affinity, so it bound more tightly to the receptor versus heroin did, and that's why you would see those differences in doses you would need to reverse the effects, essentially, right? And so again, it's going to be not only a factor of the quantity of drug at the receptor site, but also how tightly it's going to bind to it when it's actually there at the receptor. I mentioned intrinsic activity. Typically, antagonists should have no activity whatsoever. Full agonist would have full activation of the receptor. Partial agonist would only have partial activation, as the name would imply. Okay, so looking at that, those are the graded dose response curves, right? So now we're moving over to the Quantal dose response curves. And again, this is an all or none phenomenon. And I can still change what the all or none phenomenon is. So for instance, I can look at a population. I can say the percentage of people who had, say, a 10 millimeter mercury drop in their blood pressure, right? Or the number of people who had this increased level of cortisol in the system, whatever the case may be. Basically, it's an all or none. Did this person meet that parameter? And if not, then they're considered none. If they did meet the parameter, then yes, they are considered to have the effect, right? So whether it's awake or asleep, whether it's alive or dead, whether it's pain, no pain, whatever happens to be, I can change those parameters based on the study that we're doing there, right? ED50 still exists here, but this is where 50% of the population manifested that effect, right? So if I were to pipe in, say, a drug into the room right now, you guys all breathe it in, and I see when half of you fell asleep, that would be the ED50 for that drug to cause sleep, right? Or I guess I could probably use my voice as the same thing, so whenever 50% of you fall asleep, then I'll know, yes, that's the ED50 of my voice to induce narcolepsy. Yeah. Some people have said that my lectures, especially when they watch them online, there's been a great use of their insomnia, and then they learn a little bit through osmosis just listening to it when they're asleep. So I don't know. Anyway, right. So again, think about anesthesia. Think about sleep being a very good example of this. Either 50% of people are asleep or awake. Now, imagine going to surgery and you only have a 50% shot based on the dose they're giving you. You're going to be asleep or not for that surgery, right? Not good, right? This is useful for comparisons, not useful for actual clinical dosing. You typically want to shoot for 100% efficaciousness there. So anyway, again, ED50 is where you have 50% of people manifesting that given effect that we're looking for, usually the positive clinical effect we're looking for. And then a few other ones we'll talk about. They're going to be TD50. This is the mean toxic dose. And again, this is going to be, say, for a particular side effect we're looking for. So for instance, if I give you a sedative drug to put you to sleep, but the side effect is hypotension, that could be considered a toxic dose 50. I could figure out when that patient would manifest toxicity, that hypotension, and I can plot that on a curve as well, okay? Because again, usually you want to have that efficacious part, you want to have the efficacy, but you want to minimize the side effects. Some drugs you're going to be able to do that very easily, some drugs not so much, as we'll see. And then LD50, this is a point you should probably never get to, right? Typically do not want to kill your patients off unless maybe, I don't know if there's, if you're in Oregon, there's like physician-assisted suicide or something like that. But typically, you want to keep your patients alive for as long as possible, right? And again, this would be the dose where you basically are killing off 50% of your patients, right? So do you want to get anywhere near that 50 LD50? Hopefully not, right? You want to stay as far away from that as you can. So, and you can compare these curves together, right? So I can see here, for instance, here's the ED50 curve. I can look to see where my toxic dose 50 is. And then when do you start to notice these start to overlap? At this point, you're going to see once you start to get that plateau effect, once I can expect 100% of my patients to respond to that drug, this is when you start to run into the toxicity here, right? So again, to some degree, there's going to be some overlap between the efficaciousness of the drug versus the toxicity, right? Because every drug has side effects, right? Every single drug has side effects. I don't know if you guys are familiar with the Roseanne controversy that happened recently, where she said some very racist remarks, and then she said, sorry, that was some Ambien tweeting. And then the makers of Ambien came out and they said, while all drugs have side effects, racism is not one of them. I was like, it's pretty bad when Big Pharma is the good guys in an argument. Like, you know, you done screwed up pretty bad there. But anyway, but again, every drug has side effects, and so where those curves overlap with one another, you have to determine whether that's going to be acceptable for your patient or not, right? So again, sometimes you can have side effects that are completely intolerable, and they're going to stop the medication altogether because they just can't take it. Or sometimes they're going to be more tolerable, right? So it just depends. And we'll look at some examples of that. Again, the LD50 is going to be all the way over here on the right. Hopefully there's no overlap between your ED50 curve and the LD50 curve. If there is, you need to be careful with that drug, right? So it's going to be something that's going to be a lot more dangerous to be messing with. Right. And again, when you're looking at this between the therapeutic effect and toxic effect, we can calculate this ratio, right, between the toxic effect or the lethal effect versus the efficacious effect by using the ED50 as our denominator, and then in the numerator looking at either the LD50 or the ED50. I'm sorry, the LD50 or the TD50, as we'll see. So typically you want a bigger ratio because, again, if this is farther over on the right, this is going to be a bigger number. And so when you divide that by the ED50, you should expect to see a larger number there. So that would be a wide ratio, a wide therapeutic index. You want that therapeutic index to be as large as possible versus something that's going to have what we call a narrow therapeutic index. That's going to be a much more dangerous drug you're going to be working with, as we'll see. And again, this is what we consider to be the margin of safety when these curves start to overlap with one another. Typically, you'd like to have as very little overlap as possible, so that way I have the majority of my patients manifesting the good effects while trying to minimize all the adverse effects. Now, again, not always possible. In many cases, it's going to be impossible to avoid that. And so, for instance, if I was looking at, say, morphine, for example, what do we think this curve would be indicating with like something like morphine? Pain relief, right? So again, if I say, for instance, I had a 4-point reduction in my 1 out of 10 pain scale. Are you guys familiar with that pain scale? They say, on a pain scale 1 out of 10, 1 no pain, 10 I'm chopping your arm off with a rusty spoon. Where are you at? And say a 4-point reduction is my Quantal response, right? This would be that pain relief there. Now, what do you think might be a side effect here based on what we kind of talked about? Yeah, respiratory depression could be one, or you could see CNS depression, or you could see itching might be one, because morphine's a drug that causes a lot of itching. So you can define that to be anything, right? So in our cases, we probably use something like respiratory depression, right? Typically, you'd want to have a lot of patients who get the analgesia without having the respiratory depression, right? So again, the wider this margin of safety is, the farther to the right that curve is, the more safe that drug's going to be for the patient, because there's very little chance of overlapping, versus if it's very close together, that make it a little bit more likely that you're going to have some people manifesting that toxicity while still getting the efficacious effect. Again, this is the ratio, the therapeutic index. We're dividing the the toxic dose 50 or the lethal dose 50 divided by the effective dose 50. Bigger numbers are better here, okay? So again, if I were to give you, like, say, on a test question, and I were to say, here's the ED50 and the LD50 for 4 different drugs, you should be able to compare those numbers together and say, like, what the therapeutic index is going to be and which one has the widest margin of safety. So for instance, if I had, say, something like a drug that the ED50 was 5 milligrams and the LD50 was, say, 500 milligrams, and I compare that with something else that, say, was ED50 is 5 milligrams, but then the LD50 is 50 milligrams, what do you think would be a more dangerous drug? That second one, right? It'd be much more dangerous because that ratio is much more narrow, it's much smaller at that point, okay? So again, think about that. That'll be something probably likely to ask a question on and be able to look at that. And again, always look at your units. Look at things like whether we're talking about micrograms, milligrams, grams, because again, that can be very important as well, right? So again, if I had something where if I give 50 micrograms of the drug, and that's the ED50 versus 5 grams of the drug, that's a huge, huge difference, and that's great, right? You want to have as big of a ratio as I can.
High and low point for the therapeutic index that drug companies shoot for?
Wider the better, right? But it all is going to depend on kind of what you're determining is to be your toxic dose 50. Like, am I referring to, respiratory depression, or is it itching? Or, because there can be different scales there for what you're talking about. Itching might be a tolerable side effect depending on how bad it is. Respiratory depression, that's potentially deadly, not great, right? So again, it just depends on what we're looking at there. And again, the wider the therapeutic index, the better. Now, we know there are some drugs that have a narrow therapeutic index where those lines will overlap pretty significantly, and those are the ones that we're much more likely to be very careful with. Maybe we're going to try to use other drugs before using those, but in some cases, you have to use them, right? And those are usually the drugs we're going to actually measure levels of in the blood to make sure that we're at a therapeutic level and not at a toxic level, right? So for instance, there are several antibiotics that we use on the inpatient side very frequently. So has anyone ever heard of like the aminoglycosides like gentamicin or tobramycin? There's also another one called vancomycin we use for gram-positive infections. It's not important that you memorize those now, but those are ones that have a narrow therapeutic index. There's a range where they're going to be effective, and then there's a range when you go above that, you're much more likely to have things like nephrotoxicity or ototoxicity. You can have damage to the hair cells and cause hearing loss. Those are dangerous drugs, but we have to use them. They're a mainstay of therapy for a lot of infections, so we want to make sure that we can monitor that. And so that's when we use drug levels to really help us with that. Do you have a question?
What about warfarin? Does it have a low therapeutic index?
Yeah, warfarin would also be a narrow therapeutic index drug, because that would be one that, as a blood thinner, I want my patients to not clot off, but I also don't want them to bleed out, right? So that would be one where I have to measure things like the INR very frequently to make sure they're within that right range. And again, I can shoot for an INR of 2 to 3. That's my therapeutic range. If I go above that, bleeding risk. If I go below that, clotting risk. And so you're kind of walking a tightrope in those cases. That's why warfarin can be so dangerous, right? Especially like older patients, they're much more likely to fall, and they fall and hit their head, and then now they bleed. So that's not good. Anywho. So again, high therapeutic index is preferable to a low one. For instance, if you were looking at something like diazepam or Valium, right? It's an anxiolytic. We use it for seizures sometimes. Maybe have a therapeutic index of 100. Pretty forgiving in those cases there, right? Need to get a 100-fold higher dose to hit that LD50 or the TD50 versus the ED50, as the case may be. Digoxin, which you mentioned, is a heart medication. Anytime you're dealing with like antiarrhythmics for the heart, has a narrow therapeutic index, because again, as we'll see when we get into talking about antiarrhythmics and anti-epileptics, things for seizures, any of those drugs that can be used to treat those conditions can also cause those conditions. And it seems kind of counterintuitive, but that's how you change the system. That's how you deal with the disease state, is by modifying those things that can also induce the problem you're trying to fix, as we'll see. So anyway, so that would be something as narrow as a narrow therapeutic index. It would be not as forgiving. So again, I could not have big changes in dose without seeing potentially toxic effects manifest. And again, this is where we do things like drawing blood levels of the drug from the patients. That way we can determine where they're at. Are they too high, too low, right in the middle? And that's called therapeutic drug monitoring. We'll have a whole section on that later on in the class. So just know that's kind of what we're doing there when we're measuring blood levels. It's to determine that sort of efficacy. Okay, just some examples of narrow therapeutic index drugs, and these are ones that are typically going to have like a target level. So these are going to be levels that you shoot for to make sure you're in that therapeutic range without getting more toxic. So don't memorize this list or these numbers by any means, but if you work with these drugs frequently, you'll become very familiar with dealing with these. So for instance, if you work in neuro, you're going to know phenytoin. You're going to know what the therapeutic range for phenytoin is like the back of your hand, because you deal with patients who are on those drugs, right? For instance, if I were dealing with, say, transplant patients, I would know tacrolimus and cyclosporin, no problem. So you'll get familiar with the drugs individually and know those ranges. But again, if you're not sure, look it up. Again, that's the other thing I can tell you from this class. If you're not sure, look things up. Even if you are really sure, look it up anyway, because again, you can always edify yourself. You may always find there's some gaps in your knowledge. But anyway, we would shoot for specific blood ranges, blood levels in these patients, and if we're too high, then we know we need to adjust our dose down. If we're too low, we know we can adjust our dose up, because we want to make sure we're in that kind of that Goldilocks region right there. We want to make sure that it's not too high, not too low, but it's just right to treat my disease state. And again, looking at the differences in these curves here, you can see something with like a narrow therapeutic index, like warfarin, as we mentioned, versus something like penicillin. Like, it's hard to kill someone with penicillin unless they have like a severe, allergic reaction to it, but that's not really predictable. Penicillin would have a pretty wide therapeutic index, because again, I'd have to get the dose so high to kill someone with penicillin that it would be unreasonable. I'd have to give them I'd probably have to hit them in the head with the drum that I'm carrying the penicillin in just to kill them, right? Versus warfarin, like, you can have small changes in dose or even small changes in their diet could lead them to have very significant bleeds and die, right? So that is something where it'd be a very narrow therapeutic index. You need to be much more careful using those drugs. That's why sometimes we'll just try to avoid using the drug altogether and try to use something else maybe safer, right? If possible.
So is that what they tell patients that suffer from, take warfarin to eat leafy greens and?
Yeah, that's the thing where you have to have a steady intake of those kind of leafy green vegetables. They contain vitamin K. Warfarin blocks vitamin K's activities essentially to block clotting factor production. And this is what I dealt with when I was in rotations. I was in Palaca, Florida, where I'm from near there originally. Anyone familiar with Palaca, Florida? Yeah, no one is, right? It's like podunk, middle of the state. pretty redneck, right? Pretty rural. And so my first rotation there was working in a small community center, and I was doing a warfarin clinic, basically, where I would have these patients. I do a little point of care testing for their INR and check to see where they're at, adjust their dose and all that good stuff, right? And so like those people, like they eat a lot of collard greens, they eat a lot of, they're growing like spinach and kale and all kinds of stuff in their backyard, and that's what they're eating, right? That's just their diets. And so we had to say like, well, you don't want to have none. You don't want to have too much, but you want to keep it steady, right? Because that way we know that they have a steady vitamin K intake, so that the dose I'm giving them is appropriate for that amount. Now, if you had someone who said, I'm going to go on an all spinach diet, and all of a sudden they're eating spinach every single meal, then all of a sudden it throws it all completely off. And so that's why education is so important when you're dealing with drugs like this, is you're educating them, hey, be consistent on these things, or avoid this, or take this, or whatever it happens to be. Yeah, yes, sir.
Antibiotics do that as well, right? They'll throw your INR off.
Yeah, so that goes back to things like interrupting like the GI flora and vitamin K recycling in the gut there. So yeah, we'll talk about all that stuff in more specific examples when we get into Pharm 1 and Pharm. I know you guys are itching to get to the actual drugs themselves, want to talk about them, but give it time. All good things come in time, right? And then you're gonna be like, why did I ever want to learn all this stuff? These drugs are terrible. I'm going naturalistic for everything, just using acupuncture for everyone. Yeah. You'll find that, like I said, maybe job security for me to have everyone on drugs, but I usually recommend the fewer the drugs, the better is going to be good for most patients, right? So again, always utilize all your resources. So I don't mean to denigrate things like acupuncture. It's got lots of good uses, and again, sometimes medications can be helpful, sometimes not. It just depends, right? So anyway, so looking at those curves, again, know the difference between, like I say, a Quantal versus a dose response curve there, know the kind of the differences, what we're looking for. And again, they're providing us that information of efficacy and potency. Okay? And clinically, which one's always better to focus on? Efficacy is always going to trump potency. Okay, so why could patients have variations in response? Right? You may give the same dose of a drug to two different patients. You may find wildly different responses. Someone responds really well to it. Some may have terrible side effects, or some may have no effects whatsoever. So we're going to look at some different reasons why you may have some factors here that could influence how a patient responds to things. And again, if you can predict some of these beforehand, you can prospectively modify a dose or change what drug you use to try to make sure you get the best response out of that patient. So we're going to look at some different responses here. Some of these are going to be idiosyncratic. We're going to also look at things like tolerance and tachyphylaxis, and then look at hypo and hyper-reactive responses. So these are the main things we're going to look at. So idiosyncratic responses. These are going to be kind of rare abnormal responses to drugs that you would not be able to explain just on the pharmacologic action, right? So for instance, I'm looking at something like penicillin. Penicillin works by blocking production of bacterial cell walls, right? So again, it's a cell wall inhibitor for bacteria. That's how they kill the bacteria. It's how we get rid of an infection. Penicillin, as a side effect, you may actually run into potentially seeing anaphylactic reactions, right? That is not predicted by the activity the penicillin has on the cell wall. That is an idiosyncratic response that someone has, right? Not always allergies can be included with this. Sometimes you can find other things as well that are not going to be expected with the mechanism of the drug itself, right? And it may not be able to be produced with any kind of regularity in other patients. So just because I give this one person this drug and they have a really kind of odd idiosyncratic response, and then I give it to someone else, doesn't mean they're going to have that same response, right? So it's hard to predict who might have the issues there. You can find it may or may not be dose dependent, so it may give you even a small amount of the dose and you have the response, or it may, even if I increase the dose very high, maybe you don't see it for a while until these people, so it just depends. And a lot of times it comes back to being genetically predisposed to having a reaction or not, right? So for instance, if I'm looking at a drug called Primaquine, it's kind of an old school drug we use for malaria, right? Not a big problem here in the US, but however, if you have patients who are going to other countries where malaria is a concern, maybe you will prescribe this for them. Now, this is something where patients who have what we call a G6PD deficiency, this is something you'll hear, kind of a buzzword you'll hear with certain drugs, but if you have a patient who's deficient in that, which again is very hard to predict who might be G6PD deficient, you can actually induce hemolytic anemia in them, right? And again, I can't look at you guys and say, okay, well, you have G6PD deficiency, you have G6, you just can't tell, right? Sometimes you can find certain ethnicities will be more predisposed to certain genetic predispositions. That can be sometimes helpful. So I know that maybe a black population responds better to this drug versus a Caucasian population. Just depends. However, G6PD you can't really predict. So I can give someone this drug. They may have the anemia. Some other patient, most patients will not. Okay. So again, those are idiosyncratic responses. Now, looking at hyper versus hypo-reactive responses, this is where the intensity of the effect of the drug may be diminished or increased based on several factors here. So, for instance, you think, I'm sure most of you have probably taken Benadryl at some point in your life. What's the most common side effect you run into with Benadryl? drowsiness, right? Again, sometimes you use that as the therapeutic effect, though, right? So again, you can see how the TD50 can turn into the ED50 depending on what you're using it for, right? So again, drowsiness can be a pretty big side effect you see. For instance, if I have nasal stuffiness, seasonal allergies, and I have to take a test that morning, I probably don't want to take Benadryl because of that sleepiness, right? However, if I'm got insomnia because I'm up studying too late, then I can use that to maybe put me to sleep, depending. Anyway, now.
Also the other opposite spectrum too. Like I take it, it does not sleep. Get super hyper.
So that's exactly what we're going to talk about. So sometimes in some patients you'll see excitation, and it's hard to determine who's going to have that response or not. This is something you see a lot more frequently in kids as well, where like you give them a dose of Benadryl and then all of a sudden they are just bouncing off the walls, they're going crazy. Some people outgrow that, some people don't, as you can attest to. So it just depends, right? So again, those are things is going to be a hypo response you would expect to see from that. Some people may get even more sleepy than what you would normally expect from a dose of Benadryl, and that could be a hyperactive response that you would see there, right? I mentioned that CYP2D6 polymorphism in certain patients where they're actually able to make a ton of morphine out of codeine, and that's an example of a hyperactive response, where they're able to develop respiratory depression and death in some cases due to having too much of that CYP2D6 around, okay? I'm talking about metabolism more specifically later on and what those enzymes mean, but the CYP system is something we're going to talk about pretty frequently there. Anyone know what tolerance is? So being tolerant of all peoples of the earth and. I'm sorry.
Like the response is diminished.
Yeah, basically you kind of get used to the response, right? Because again, the body likes to maintain homeostasis, right? So again, if I give something that lowers my blood pressure, the body doesn't like to have that lower blood pressure. It's probably going to try to do something to compensate and try to raise it up, right? So in some cases, you may find that drugs will kind of have a diminished response over time. And so, is there any way to overcome that? Give more drug, yeah. So I can overcome that by giving more drug. You see this very frequently with CNS depressants, opioids, anything that's working with the CNS because, again, they like to maintain that homeostasis. You have a question?
What about a drug holiday?
Talk about drug holidays in a second. Maybe like spring break or something, go down to Cabo and, just
No. Like,
there's a lot of drugs there, so it's a holiday, right? Just kidding. That's something different. I'll talk about that in a second. Yeah, but basically you can see, especially with like opioids, like so for instance, you may start on imagine like a cancer patient who's got severe pain. They're taking, say, morphine for their pain. So maybe they start off, say, taking 10 milligrams, 3 times a day or something like that. And then over time they realize, man, this pain is just still here. It was good for a while, and then now it's come back even stronger. They're going to have to increase that dose higher and higher. And so there's been some cases where you'll have these like 90-year-old grandmas and grandpas who have the severe pain on opioids chronically. They're taking doses that would kill a normal person just in one-time dose, right? Especially kids get into it, teenagers are getting into grandparents' medications. You think, oh, grandma only weighs 80 pounds sopping wet. Like, there's no way that she takes like a heavy-duty dose of this drug when she's really taking something that's going to kill an elephant, basically, right? Because you can develop a lot of tolerance to these medications here, right? So that's one thing you see. Benzodiazepines are another big one. Those are used for anxiolysis. They're used for seizures. Again, the other thing we see with tolerances with these drugs, usually when you take them off of the drugs as well, what can happen? Yeah, withdrawal is going to be a big phenomenon as well, because again, they are so used to having that drug around, their system, that's the new normal. When you take that away, they're going to have the opposite reactions that can occur there. So we'll talk more about that a little bit later on.
So as long as it's a gradual increase, so for them to have an effect, like they won't ever die by then?
Potentially, right? So you can potentially overdo it, right? So maybe if I cause too big of a jump, but yeah, if I cause a steady increase over a long enough period of time, they should retain, they'll probably still have some side effects associated with it. So, for instance, like, you really never get tolerant to the constipating effects of opioids, right? So, you have these patients who are on huge doses, and that constipation is still there, and they're just completely stopped up, and that usually is a big side effect you see with that. But they can be on these huge doses, and the respiratory depression, they're tolerant enough to that to where they don't die from that. Right, so it just depends on the drug and the time scale for things, right? But stimulants like caffeine, who's abusing caffeine right now? Yeah, probably everyone in the room almost. So again, this is one of those things where you'll probably notice this through your PA school career, but maybe one Monster Energy drink in the morning is enough to get you through the day, and then all of a sudden you're like, man, I need two Monster Energy drinks. Now I need 3, and now I need like 5 a day just to keep me normal, right? And caffeine withdrawal is no joke either. So again, these tolerance is a big effect you're going to see with a lot of these drugs. They can be overcome with dose. So by increasing the dose, you can still get some effect out of that, right? Yes, ma'am.
So when you drink coffee and then you switch over to like Monster drink or another energy drink, is that like similar to the same caffeine ingredients or?
Well, yeah, I mean, caffeine's caffeine essentially, right? So you may find there's a little bit of difference in absorption potentially. Usually sometimes like sugar can help with like absorption of things if you were to switch like a full sugar sort of energy drink, or it just depends on several factors. But yeah, caffeine's caffeine. So, you could potentially switch from using coffee to just caffeine tablets and you potentially get the same effect out of it.
So what does that do to the tolerance? Like if you were to stop drinking caffeine completely, and then you go back to drinking again, is your tolerance going to stay about the same, or?
It depends on the time frame, right? So I can go. So like me personally, like I said, I probably have enough caffeine in my system to probably kill an elephant, and I just drink it now just to keep me normal, right? So if I stop that for like a day or two, I'm going to have those withdrawal sort of symptoms there. But if I were to go back on the same dose I was at before, probably would be no problem, right? Probably get the same sort of effects there. However, over time, if I were off of that drug for long enough, you would see sort of a resetting of the system into the point where you would have lower tolerance than you would normally, right? So for instance, we have some patients who may go into rehab for, say, opioid addiction, right? So say they're usually use heroin, and so they've built up tolerance over time. They use a huge amount of heroin based on when they started, and then they go into rehab, right? So maybe they go cold turkey, or maybe they're on something else for a while, and they start to lose that tolerance. When they come out, if they relapse, sometimes what they'll do is they'll go back to their original dose of heroin they're using beforehand, and guess what? Now they're not used to that anymore, and they die. That's something you may potentially see.
So is it downregulation of the receptors?
It could be downregulation, could be upregulation, depends if you're using an agonist or an antagonist. So again, it could be either one depending on the situation there, for sure. Yeah. So again, just know that in a lot, the answer to avoid a lot of these like withdrawal symptoms is to titrate down slowly, right? That's gonna be always the thing there. So if I can give them, say for instance, if I was drinking, say, 6 cans of soda a day or something for my caffeine intake, and say then I slowly went down to 5, 4, 3 over the course of several weeks to months, then that would help to mitigate those withdrawal symptoms, right? So again, it's always about titration. Now, tachyphylaxis is a little bit different than tolerance, but basically it's where something where a drug loses its effects, it loses responsiveness, and it doesn't matter how much I increase the dose, I don't get any additional effect out of it. This is usually where you're depleting like a cofactor or an enzyme system has been exhausted, and you need to give the patient time off of the drug in order for it to become effective again. Okay, a really good example of this would be something like nitroglycerin for chest pain. If you're ever familiar with nitroglycerin, patients who are on it for not just like sublingual every time they have chest pain, but they're on it like on a daily basis. For instance, like nitro paste or something like that, you put it on 12 hours on, and you have a 12-hour off period. If you left it on 24 hours a day, you eventually deplete that nitric oxide pathway to the point where, when they did have chest pain, and I give them more nitroglycerin, it's not going to be effective. It doesn't do anything, right? So that's not good. They need to have a nitrate-free period, usually 12 hours out of the day, to replenish that system. So that way, when they do put it on again, it becomes effective again. So usually, you would do things like time it to where the patient's going to be most active, when that's when their heart's going to be likely requiring the most oxygen, right? So if they're going to wake up and go to work, that's the time they need to be on it versus if they're asleep all night. That's one example. It's commonly seen with things like amphetamines, nicotine. A lot of stimulants will do this, where basically if you deplete the CNS of the catecholamines that cause its effects, like norepinephrine and epi, eventually you just tire the system out, right? So it doesn't matter how much more amphetamines I give these patients, they just don't have any more neurotransmitters to release, essentially. Okay, that makes sense. So again, I cannot overcome this with dose versus tolerance. I can't overcome with dose. Okay. Then some other mechanisms for response and variation. So again, you can do things like alter how much drug is actually getting to the receptor. You can see potentially if there's variation in natural ligands that are naturally occurring that may be interfering with the drug, that can change the response here. You can change the number or the function of the receptors, as we'll see. And we're going to see that if you change some of the downstream responses, say some of the secondary messenger systems, et cetera, you're going to find that can actually lead to some change in response. We're going to go over each of these individually now. So looking at the actual difference in the amount of drug that makes it to the receptor, usually these are going to be pharmacokinetic factors. So for instance, if I can change how the drug is absorbed or excreted or metabolized, that's going to modify how much drug actually gets to the tissues, right? So for instance, if I'm on a drug, for instance, there's one called carbamazepine. Tegretol is a brand name usually used for seizures or for like bipolar disorder. It's a mood stabilizer. You find that if you look at the dosing of it, I give anyone carbamazepine? Probably not. Undergoes this thing called autoinduction of metabolism, where basically it upregulates its own enzymes that metabolizes it to where I need to start at a low dose, say 25 milligrams on day 1, or say on week 1, week 2 I up it to 50 milligrams, and then up to 75, and then up to 100, because as those enzymes upregulate, they're going to be able to be more likely to metabolize the drug, and my levels will drop. Right, so I need to kind of constantly increase that dose to make sure that I overcome that metabolism effect. Right, because the less drug that's available to get to the receptors, less effective the drug's going to be. Right, because I'm metabolizing more of it. Other things that can happen here would be change like in age, gender, weight, disease states. All of these can have factors on how well a drug is going to get to its target, both increased and decreased effects, as we'll see, because we can change things like the volume distribution, we can change the metabolism, etc. Some other cases here, things like we have certain drug efflux transporters, which are basically, these are called multi-drug resistance proteins that are responsible for things like excreting drugs into the GI tract to prevent them from being absorbed. If those are upregulated, that can decrease levels of a drug. You can find that in some cases, things like cancer cells can become resistant to some of these drugs because they have actually had these mutations where they're more likely to be sending out these proteins and spitting out the drug instead of it getting into the nucleus to have its effect, essentially, right? So just like bacteria can become resistant to antibiotics, your cells can do the same thing in some rare instances, especially like cancer, you know. Looking at the endogenous ligand concentration, so this is basically where, for instance, I have a drug like propranolol, which is a beta blocker, right? So where do our beta receptors lie? Anyone know? The heart's a big one, right? So beta 1 or 2, anyone know? Beta 1. So beta 1 is a big, is the big kind of adrenergic receptor you're going to find on the heart that increases contractility, increases heart rate. So in some cases, you can give a drug called propranolol, which is a beta blocker. It will block that effect. And so what do you think it would do to heart rate? Probably slow it down, right? So you can use this for several different disease states and indications. For instance, I could use it for blood pressure control, use it for tachycardia if I need to slow down the heart rate, but in some cases people will take it for stage fright, right? So for instance, if I got really nervous before I came up and talked to you guys, I'm activating my sympathetic nervous system, I'm going to be tachycardic, I'm going to be sweating, I'm going to be tremulous, and I'm going to sound like an idiot, right? Fortunately, I've been doing this long enough, I don't have to worry about that with you guys. So, for instance, you know, if I were to pull one of you guys out, call one of you to come up here and then start giving the lecture, you'd probably be pretty nervous, right? Your sympathetic nervous system would be very activated. You'd be releasing a lot of norepinephrine and epinephrine into the system, okay? This means that beta blocker work perfect for you because you can block those receptors and prevent those catecholamines from interacting with the system. Me, on the other hand, I've been doing this for so long that it doesn't really affect me that much. So I don't have a lot of those excess catecholamines. If you took the beta blocker, it really wouldn't do a whole lot for me, right? So you can see in those two different situations where the drug would be effective for one person, because they're in a different situation than someone like me who would not be that affected by it, right? Now, if you said, okay, go up and talk in front of TV in front of, you know, 1 million people, then that would be a different situation. Now, my endogenous ligands are going to be upregulated at that point because now I'm nervous, and then the drug can be effective then, right? So again, there's some cases where the drug may become more or less effective based on ligand concentration. Now, looking at the actual number and function of receptors, typically if you have something like an antagonist on board, you're going to find upregulation of receptors. If I have an agonist on board, typically you find downregulation that occurs typically. But you may find that sometimes hormones can be affecting things like receptor function as well. So for instance, when you think about the thyroid hormone, you think about hyperthyroidism, what do you think it does like metabolism and to things like thermogenesis and all of that? Usually increase, right? Usually thyroid hormone is going to be sort of a stimulatory sort of thing. You can find that by modifying how much thyroid hormone you're releasing, you can actually upregulate the number of beta receptors on the heart, which can see things like more tachycardia, more hypertension, etc. Because of that, right? So that changes those number of receptors that are there. And then in some cases, you may find that tachyphylaxis intolerance is actually a feature of down-regulating receptors or maybe up-regulating as the case may be. So by changing that, you can make the drug less effective potentially. Okay. Some receptors will become desensitized after repeated or continuous administration of like an agonist or an antagonist. So a good example of this is there's a paralytic called succinylcholine, right? Succinylcholine basically looks just like two molecules of acetylcholine put together. And if you look at like skeletal muscle function, when the nerve terminal goes in the motor neuron goes into the nerve terminal, it's going to be releasing acetylcholine to cause skeletal muscle to contract. If I give a drug that looks just like that and it sits there on the receptor and keeps hammering and keeps activating, eventually that desensitizes, and that can eventually lead to paralysis, right? So again, that's why we actually call it a fasciculating neuromuscular blocker, because when you are depolarizing neuromuscular blocker, because when I actually give that initially, it will activate the receptor. You see patients kind of fasciculate, and then they become paralyzed at that point because they desensitize the receptor, working less effectively. Now, that's one way you sometimes see drug effects can be diminished, or in this case, it's actually how the drug works altogether, right? This is usually a defense mechanism by the cells to try to prevent further damage, because usually overactivation of these receptors tends to cause cellular damage due to these downstream effects that are occurring there. And again, usually if you find that there's repeated desensitization or desensitization occurs to where the drug has no effect anymore, that's again tachyphylaxis occurring there. You may find that receptors are still present, they're just really not responsive, right? So it's not a case of up or down regulation, they just become insensitive to the agonist or the antagonist. And so you could see potentially when you're giving these drugs, for instance, if I was to give it several repeated administrations, you see that the max efficacy may actually go down as those receptors become desensitized. However, if I give it a period of time, if I wait a few hours and then re-give the drug, typically you'll find a resensitization that can occur, and then the drug works just like it did before. Okay, so sometimes they just need a rest period where it helps the drugs to work a little bit better on repeated administration. Okay, so in some cases you can actually find what we call a rebound phenomenon. Anyone know what that might mean? Say rebound phenomenon.
It's kind of like an NSAID headache, right? If you take it too much, then if you don't take it, then you get a rebound headache.
There you go. Yeah, that is essentially what we're seeing here. So basically, if you're using a drug to treat a certain thing and then you take it away and it causes the opposite effect. So for instance, if I were to give you a drug to help with your blood pressure and then all of a sudden I take it away and all of a sudden your blood pressure goes even more hypertensive than it was beforehand, that's called a rebound phenomenon. Another really important one you'll see, especially with like a lot of nasal stuffiness, is people take Afrin nasal spray. If you take that for too long, you become really dependent on that, because if you get off of it, guess what happens? Rebound nasal stuffiness is really bad. I knew one pharmacist who had basically 3 bottles of Afrin on either end of the counter that he was working at, and he was just using Afrin all day long. He was kind of addicted to it essentially, to the point where he just had to have it, otherwise his nose would just get so stuffed up. It was terrible. Anyway, this can happen, especially with a lot of cardiovascular medications, and I'll show you what it looks like in a second. But basically, if I were to block up all these beta receptors, the body's going to want to do something to try to counteract that. So typically what it does is upregulate the number of receptors that are available. Now, I may have enough drug around to block all those up too, so there's kind of a balance that's maintained there. But what happens if I take that drug away all of a sudden? Now I have all these receptors that are available there. Now they're going to start to interact with the endogenous ligand, and I can see this rebound phenomenon where the blood pressure may go even higher than what it was actually originally. Okay, which can be bad, because that can actually potentially lead to things like heart attacks being developed, especially with beta blocker rebounds.
That can happen with like PPIs as well, right? Like
Clinically, I don't know that it's as important, but potentially you could see that where you're blocking like stomach acid production and maybe you have a little bit of upregulation. I don't know. I haven't run into that too frequently. This is more like a because that'd be more like kind of like a minor sort of issue compared to something like inducing like a heart attack in these patients, you know. But yeah, potentially I guess you could see some of that. But I imagine it's mild. But so anyway, this is bad because, again, if I am taking a beta blocker to slow down heart rate to decrease myocardial oxygen consumption, and all of a sudden I take that away, and now I have all these extra receptors that are available for epinephrine to interact with, now all of a sudden heart rate's going to increase, contractility increases, and all of a sudden oxygen consumption goes up, and guess what? Now I got an MI that can develop there because I'm not able to supply enough oxygen to the heart potentially. Right? So that can be a very bad thing, can potentially kill patients. So you imagine here, you have your receptors, they're located here, you have your endogenous ligand. Let's say I add in, say normally you'd have, say, a heart rate of 75, 145 over 90 blood pressure. Let's say then I were to add an antagonist and I could bring down the heart rate, bring down the blood pressure to normal levels. And then as a response to that, I'm going to have this upregulation of the receptors. If I take that drug away all of a sudden, you're going to find they have a lot more receptors that can interact with the natural ligand, and now the blood pressure and heart rate have gone up even higher than what they were at baseline. Okay. Now this is not a permanent effect, because eventually you're going to have downregulation. Once they sense that, hey, there's too much activation here, it'll then downregulate the receptors back to the normal number. However, in the meantime, if you induce a heart attack and you kill your patient, then yeah, it's no good, right? Then we'll not really have the time for that to occur. You can also have things like genetic factors affecting the number of receptors that are available to interact with different drugs. So for instance, you can find that if you have a certain deletion, then again, don't memorize this specific example, but just know if you have a particular deletion, you may have increased cardiovascular response to stressors, right? So maybe you have bigger changes in blood pressure and heart rate due to things like epinephrine being released from the adrenal glands. You may find that certain populations may be more prevalent than others. So for instance, African Americans may have a 10 times more likelihood to have this mutation than a Caucasian patient may. All just depends. And again, these may be of varying clinical relevance. Again, it may dictate, okay, well, say for instance, if I have an African American patient, I'm going to use this type of drug, versus for a Caucasian patient, I'm going to use this type of drug. Sometimes it can be that black and white. No pun intended. In some cases, though, you can find that it can be more of scales of gray there, where you can see where, okay, well, maybe this drug works good for this patient. However, they didn't have that mutation, so it actually is a kind of a moot point, right? So again, it just depends on the situation. You'll kind of learn that, especially when we talk about blood pressure management. You're going to find that, hey, usually for like black patients, I'm going to start with something like a hydrochlorothiazide or calcium channel blocker. For Caucasian patients, we'll start with an ACE inhibitor. But then eventually, once those drugs fail, they're all going to end up on the same drugs anyway. So again, it can be sometimes a moot point depending on the situation. Okay, sometimes you'll find changes that can happen kind of distal to the actual receptor itself, some of the downstream effects here. So for instance, if I'm giving a beta blocker to help lower the blood pressure, you may find that working with the beta blockers in the heart there, it doesn't really make sense that just blocking the effects of epinephrine on the heart, like how does that cause the downstream effect of blood pressure changes that can occur there? However, what you're going to find is that the body likes to compensate for these things. You're going to find that the body likes to maintain that homeostasis. So if I give a beta blocker and it drops blood pressure, you're going to find that the kidneys are going to detect that, and they'll have some compensatory response that they actually upregulate things like angiotensin II. They'll cause vasoconstriction to bring that blood pressure back up. So a lot of times what you're finding is that the body's trying to fight yourself when you're giving these medications, and so you either need to give a big enough dose to overcome that, or I may need to potentially give an additional drug in order to deal with that. So for instance, I have a patient who's on a beta blocker for the blood pressure management, but then all of a sudden they have this kind of ramped up angiotensin II, and then I give them something to block that. And then now I have both of those kind of mechanisms kind of covered for. So again, that's why sometimes you'll see patients on multiple drugs for the same thing, is to counteract those kind of homeostatic sort of mechanisms there. Okay, so looking at selectivity, you guys mind if I might go a few minutes over? Is that okay? I want to make sure I cover all the material for your test. So again, typically we like drugs to be very selective whenever possible. If they have low selectivity, that means they can interact with all different types of receptors. That leads to more toxicity, as you'll see. So for instance, with organophosphates, anyone ever heard of organophosphate pesticides? These are old school pesticides that were very effective at killing insects. However, they were not very specific for insects, and they would kill us too, potentially, right? And in fact, if you go to certainly developing countries, you'll still find there's a lot of deaths associated with organophosphate poisoning. However, nowadays we have a little bit safer products called pyrethrin. So a lot of the insecticides you buy from the store contain these pyrethrins that are very selective for the bugs, not so super selective for us, which is good because if I have a kid that accidentally gets into it, that won't kill them, versus organophosphate, it definitely could. Similarly, if we're dealing with things like antibiotics, I want drugs that are going to be effective for killing off the bacterial cells, but leave my cells alone. That's good selectivity. Some things like cancer drugs, not super selective. They can't tell the difference between a cancer cell and a healthy cell, so they hit everything essentially. A lot of the older school sort of cancer drugs. So good selectivity is usually better because it means less side effects typically. And so you can look at that selectivity by looking at things like ED50s. You can look at and comparing those to see, just how much affinity the drug's actually going to have at the receptor itself. And again, when selecting these drugs, and usually a lot of this is done before during the clinical trials, et cetera, they'll be able to break these down these effects into both the therapeutic effects and then also toxic / sort of side effects there. And again, you can find sometimes that the beneficial and the toxic effects are mediated through the same sort of effector pathway, right? So again, this would be very difficult to kind of break these apart because again, it's all through the same mechanism. So a good example would be warfarin, right? So again, I use warfarin when I want to thin the blood because the patient's at risk for developing a clot. What's the main problem with warfarin? People can bleed on it, right? Because I thin the blood too much. That's the same exact mechanism. That's the tight wire I have to kind of balance to make sure that I get the right amount of drug to cause the blood thinning that I need without causing too much bleeding risk to occur there. However, those patients are still going to be just more likely to bruise anyway because I've thinned the blood. So again, bruises are something they're going to experience. If they cut themselves, they're going to be bleeding for longer. That's through the same pathway there. We can't really select out for that because again, it's all through the same mechanism. At that point, you have to weigh the benefit versus risk, right? Same for insulin. When I give insulin, what is that going to do? It's going to lower blood sugar. Right? If I lower blood sugar too much, hypoglycemia, and the patient passes out, right? That's not good. So again, you have to make sure you're giving just the right amount to get the blood sugar right where we want it, but not too far down. Again, all through the same pathway. Sometimes you can find where some of these pathways will occur through different receptor pathways. And so, for instance, I can find that when I give, say, a steroid, and you guys heard the term glucocorticoids before? It's called glucocorticoids because they maintain or they help to change glucose levels in the body during stress responses. Well, for instance, if I have a patient who's developing, say, like a COPD exacerbation or asthma exacerbation, I give them steroids. I give them systemic steroids. Do those steroids know to go right to the lung and work there? No, they work all over, right? So that's where I can see issues where glucose intolerance, fluid retention, all those different side effects that can occur there. Now, sometimes you can get around that by giving drugs via certain routes. So, for instance, if I have someone with a respiratory issue, I can give them inhaled steroids. Those inhaled steroids only work in the lungs and don't really get out systemically. So that's one way you can get around that when you have these side effects being mediated through kind of different tissues or different pathways potentially, right? And again, when you're looking at drug selectivity, you're going to find that, or at least receptor selectivity, you're going to find there's different subtypes of receptors that are out there, and certain drugs will be selective for one versus another, or they may be unselective, right? When they're unselective, they're going to be affecting each one of them pretty much equally. However, sometimes we can separate that out and get drugs that only maybe affect one or the other. This helps to limit side effects in most cases, or may have totally different therapeutic effects whatsoever. So, for instance, when you have something like an H1 blocker versus an H2 blocker, H1 blocker would be something like diphenhydramine, used for allergies. An H2 blocker is more going to be used in the GI tract, and that's going to be something like Zantac, right? It's going to help with GERD symptoms. So totally different therapeutic effects because the drugs are selective for those different receptors. COX-2 inhibitors is something you're going to see where by being selective for a particular COX enzyme, you can mitigate some of the side effects you'll see with these drugs. So again, usually more selective a drug is, the better off we're going to be from mitigating side effects. What you're going to find, though, is that as you drive up the dose of a drug, you lose that selectivity. So you can find that as I drive up the dose of a drug higher and higher, you may find that there's going to be bleed over effect where maybe I can have, the COX-1 being inhibited by a COX-2 inhibitor because the dose is too high. So again, just kind of keep that in the back of your mind that selectivity is all relative to dose. And again, sometimes we're going to actually find that side effects of drugs actually lead us to developing new uses for them. So, for instance, minoxidil or Rogaine, it would be used to be used decades ago as an antihypertensive. It was kind of a crummy antihypertensive, as you'll find, but they were giving the patients this drug, and all of a sudden they realized they're growing all this hair. Like, that's kind of weird. What if we just rubbed it on top of their head? All of a sudden, okay, now we can fix some limited baldness there. So again, sometimes you'll find that drugs have different uses in their lifespan based on some of these side effects. And you guys remember, I don't know if I mentioned it in a previous lecture or not, but there's a drug called Latisse. I'm familiar. What does Latisse do? Since eyelash, originally is a glaucoma med. We'll still use that for glaucoma because it helps decrease intraocular pressure. But a side effect they noticed from that is that, man, these glaucoma patients have these big, luscious, long lashes. It's wonderful. What if we just give it for that? And then all of a sudden, okay, now we got Latisse, right? So again, you can find that sometimes drugs will have new uses based on kind of side effects, essentially. Again, typically we want to have drugs that are very selective, and we want to have, obviously we'd like that for drugs to be potent, but potency is not really the big thing we care about. Efficacy is always going to trump potency in these cases there. And again, more selectivity usually means less toxicity for the most part. Okay, so I know that was quick, but I want to get through all the topics before your test. This is going to be next week, so I believe it'll be a shorter one. You guys will be here at 8, and then class will start at 9, so that way we can make sure we get through all our material, and I'll get that test over to them pretty shortly so that we can get it all ready to go. So any questions I can answer before I let you go?
Is it anything extensive?
I don't remember. I will double check. It might be on paper. It's going to be a shorter one. It'll only be like 25 questions.
Just like an example of questions you ask on the exam. Like obviously not, but just kind of get our heads thinking.
So I might ask a question such as, so based off of this, I'm giving a drug that blocks beta receptors. What do you think might be a potential downstream effect of this, or a potential consequent effect of this? And I would say either downregulation of receptors, maybe upregulation of the receptors, no change in the receptors, or something else, right? Probably some red herring sort of answer there. And so you would need to know that based on the fact that it's an antagonist is blocking those receptors, that upregulation would be the thing that would want to occur there, right? To again maintain that homeostasis, right? Versus I could change the question around and say I was giving an agonist, you expect to see downregulation to occur there. Okay. Again, specific examples I'm not going to ask for. If I bring up a specific example, I will illustrate out the point that I'm trying to make with that, and then based off the concept, you'll be able to answer that question. Okay. Again, please do not overthink my questions. I'm not trying to trick you guys. I am not as mean as the other classes have probably told you, at least not until Farm 1 and Farm 2. Then it gets a little bit tougher, but this is all concepts. So again, just by nature, this class is a little bit easier than you're going to see with Farm 1 and Farm 2.
And video for this class today will be posted.
I'll post it up today, probably, yeah, because I'm going to work after this. So this is also work, but it's the other work. I have like 4 jobs at any given point, so yeah. I believe it'd be 25 for this one. So again, it's worth less overall for your whole grade, but it's a little bit smaller, and it's only over a small section of stuff anyway. If I had to make 50 questions off these 2 sections, it'd be pretty tough.
So if we pretty much have everything on the slides, it needs to be good, or is there like reading material?
I'm not going to have anything from any reading material. If it's in the slides, and then it's fair game, I would say. Most people can get away just looking. And again, even if you wanted to, you could look at the all my stuff on YouTube is all public, so you can go back and look at the previous year's pharmacodynamics. And you can or intro to farm. You can review those if you want to see if I said anything different. But it'll probably be very similar. Slides are going to be very similar from year to year. But yeah, I don't foresee anything to be different there. Yeah, you could YouTube, you could email me, we could talk about it, so if there, and I really stress email me sooner than later, right? So again, if it's going to be Thursday night at 2 a.m., I'm probably not going to respond to you, right? I'm probably going to be in bed by then. However, if it's, Monday, I can definitely get back to you in a timely manner and answer any questions you have. So I definitely recommend trying to look at it a little bit sooner, so that way you can see if there's any kind of big, gaps in knowledge you can try to review and we can talk about it.
The only calculation for the exam is the TI,
So yeah, there may be a question like that where you're just comparing like a ratio, right? You have like a TD50 to an ED50, right? So that would be the only thing. So no actual math. We'll do some math for the test. We'll do like later on. We'll get into like things like PEDS dose calculations and things like that. That will be on the test. But for this one, really that will be the only math you'd be expected to look at. So it's really just comparing two numbers.
What's the format of your test?
The short essay. Okay, no, no, it's just all multiple choice. You guys do 5 answers, which is always kind of it's difficult to. It's more tough to write those kind of questions to come up with the 5th answer that's not like ridiculous compared to just doing 4. So you guys' tests are always a little bit more difficult to write. But yeah, I think there's 5 answers. I never do all the above or none of the above, so you don't have to worry about those kind of questions. And it's just straightforward. You know, I try not to do negative questions. I don't say like which of the following is not something, or all of the following except. I try not to do those because those can trip people up. So I try to make it just more of a positive thing. Not positive like you guys are going to like it, but positive is like, which one of these is true, right? That would be the type of question I'd be more likely to ask. Any other questions? Don't stress too bad. Again, concepts. Know the concepts. If I put a specific example, I will explain everything about it to make it so that you guys can figure it out based on concepts, okay? All right, I'll see you next time.